take your question, and then maybe that'll, the same questions that one person has is the questions that everybody has. So ask me about Friday. Have it.
For the general survey, when you're looking over the basic body habits and then skin as well, do you just want us to say, I'm looking at their general body habits, I'm looking to make sure they're alert and conscious, or do you want us to kind of say something like, I'm looking at their body habits to see if they are in healthy condition, if they're too skinny, whatever it may be, or stuff like that?
I think you could do either.
Yeah.
Either would be fine. What I don't want you doing is describing the body habits of your classmates out loud. That can make you not have friends really fast. So just say, I'm noting the body habits of this patient, their muscular build, hectic, whatever. If you say, I'm noting the body habitus, and the person who's proctoring you asks, well, what does that mean? Be prepared to answer that. So I think I would probably just say, I'm noting the body habitus, and then if they ask me a question, be prepared. I ask questions. If you're in my room, I ask questions all the time. Don't let it get you off track. Don't have it memorized just as a memorization table. Know what you're doing. That's the big thing. If you know what you're doing, I can interrupt you and stop you, and I will if I have a question whether or not you understand what you're doing. I don't want it just to be something that you memorize. I want you to know what you're doing, and that's why I stop and ask you questions. I'm not going to ask you what that blood pressure is or something, because again, I don't want that said out loud, but I want you to be aware of what you're doing. Yes.
Do we explicitly state that we are going to display professionalism?
Yes. Yes. And I know it seems weird to say that, and you will never say that to a patient. They're just assuming you will do so, but I figure if I get you to say it enough times, it'll sink in. You know, there's a method for this madness. There's a reason for it. So please state that. Yes.
Do we need to, particularly on general surveying, do we need to go in that particular order that's listed on?
It doesn't have to be the exact order, no, but it needs to be in some semblance of order, because that's one of the things we're looking for. We want to make sure that you're developing your skill in a way that makes sense. And some of the things we say up front here seem contrary to other things that we say, because everybody has their own way of doing it. But even though everybody has their own way of doing a physical exam, there's usually some semblance of order. Now, I've run into physicians who don't have any semblance of order whatsoever, but for the most part, they do it in some systematic way, and that's why we're teaching it this way. But it doesn't have to be exactly like that, no.
When you palpate the blood pressure initially and get your number on the left arm, and then I go to the right arm, do you expect us to palpate it a second time and then do the blood pressure?
Unless I tell you it's deferred.
Okay.
Just do everything that you did on one arm on the second arm unless we tell you that it's deferred. And that's because maybe we didn't, we're not convinced that you knew what you were doing on the first arm. So we're going to give you a second try. So do everything that you would do on the other side, and even in the positions.
Thank you. Okay, that's right.
Even in the positions, all three positions, unless we say it's deferred. If we say it's deferred, then that's different.
I had two questions.
Okay.
So it's about doing everything on those lines. However, in different positions, we just measure the cuff once on each arm.
Yes, measuring the cuff, you don't have to do it in all three positions. That wouldn't make sense.
My other question was one of the senses, assessing for fixation and cortical sound. That's something you should verbalize, say that.
Yes.
Noted they stop using the device.
Yes.
When we're finding the blood pressure, heart rate, respiratory rate, do we have to say those numbers out loud?
No, I don't want you to. And if the person who's proctoring the exam says, well, what did you get? answer. Is everybody listening? This is your answer. Professor Patch told me not to tell you. Professor Patch said that that is confidential information. We will assess your ability to hear and determine a proper blood pressure using Mediman. All right? So there will be a time that you will be assessed and have to tell us the number, but it's on an inanimate object. Right? I don't want you saying out, wow, I got 320 over 140, and your classmate fall over in disbelief and faint because they think they're going to die. I don't want any of that information out there.
When it comes to finding the heart rate and respiratory rate, do you want us to say we're doing 30 seconds? I'm doing it for a minute, and afterwards, while I did 30 seconds, multiply by 2, I also look at the respiratory rate.
You can do it either way. As long as I know that that while I'm checking the pulse for the second 30 seconds, I'm actually looking at the chest to see what the respiratory rate is on that patient. As long as you've convinced me that that's what you're doing, I don't care how you say it.
You mentioned that we don't have to measure the cuff.
That's correct.
But we can just do it for one arm, or should we do it
You
both
need
arms?
to do it both, because there will be people who have asymmetrical arms, where they may be really developed on one side and not on the other. One of you two.
I just want to go on with that and confirm something. So we're looking for the palpable systolic in all 3 positions on both arms each time,
Yes.
unless deferred.
Unless it's deferred.
Okay. However, this is more of just recognizing that you know the sequences, not that you're getting an accurate blood pressure, an accurate respiration, or accurate.
Well, there's no way we'll know whether it's accurate, because I'm not letting you tell them, and we don't have time to take everybody's blood pressure again with our own ears. When we'll know that it's accurate is when you're tested on Medi and you get a totally random weird number, and we have it set at a certain number. So if you're unsure how to do blood pressures, practice and have somebody do it with you that knows how to do it. If you're not sure what you're listening for, and it takes a little while to hear that, especially when you're in the lab and there's all kinds of noise going on. But if you're not adept at taking a blood pressure by the end of this semester, then I'm going to worry about you, and I'm not going to let you take blood pressures at Project C. So just make sure that you feel comfortable doing it, and if you're not sure what you're hearing, ask for help. Yes.
We're supposed to verbalize that we're waiting 1 to 3 minutes between position. Are we to stand there and wait? Or
No,
what-
just say, I would wait for 1 to 3 minutes, but, okay, and then if you're in my room, I'm gonna say, okay, 2 minutes is up.
Okay.
So did I not have to do this anymore?
That is correct. You already passed this class once.
So you want to say that on the mic. Versus sitting, wait, 1, 3 minutes, lay down, follow them.
Yep.
And,
Yes. Yes.
you want us to do it in that order?
It can be in any order you want.
Can you clarify for, I think group B, Dr. Sparker told, she was presenting the whole, the length of the cuff, the length of the arm, and then Dr. Kant clarified for some of us that, I don't know if everyone got that message, 78% all the way down the arm until the
No, it's not a, it's the circumference of the arm.
Wait, what was the question? Say that.
Letters.
Yeah.
It's the circumference, not the length of the arm. That's interesting. Obviously, it's 40%. You take the width of the bladder. You know, the bladder part of the cuff is the part that inflates. On some of the newer cuffs, it's hard to tell where the bladder is and where it's not. The older cuffs, it's easy because you insert the bladder into the material. But if you have one of the newer cuffs, you can see the seam that goes around. It must be glued together somehow with some kind of super duper glue because it never comes apart. You you can see where that bladder is by where the seam is. If you're unsure tomorrow, tell me in lab, because we have lab together tomorrow. So if you're unsure of where the bladder is, and then when we're in lab tomorrow, I'll show you all the 40-80 rule. Just remind me, because we'll be talking about HEENT, and I'll forget we had this conversation. So remind me, and I'll show you all the 40-80 rule. Yes.
Do we wear lab attire?
Yes, you wear lab attire for lab and for practical exam. You'll see some of you have 8 o'clock, so you can come in your lab attire, but bring your other clothing with you because you can't wear your lab attire for other classes. Right? And the other thing is with this practical exam, you're allowed 20 minutes, but most people get done like 10 minutes. So if you're scheduled, if you're the second group to come early. Don't wait until that time is up, or we're going to be coming and looking for you. So be ready early. And if you're in the third group, be ready even earlier, because we're going to get finished much quicker than what that time says. Yes.
There's preferred room that you would like to be in exam room.
I mix the exam rooms up. I put them in different rooms. There's one professor that always ends up in one because he likes that room, but everybody else I mix them up, and I don't put the names on there on purpose because I don't want people to start freaking out ahead of time. Just freak out when you find out who's in on that. No need to worry overnight. Yes. Yes. That's correct. And that reminds me, something else I wanted to tell you. Up until this year, we've allowed people to gather outside the exam room door, but we're changing that this year, and that reminded me. I'm glad, because I haven't told you this, I don't believe. Stay in here until we call you. We'll come get you. So just stay in here until it's your time, because it gets noisy. It gets too noisy outside the doors, and it's like walking, through a maze or something, trying to get through, and it gets a little bit noisy on the outside. So come here and report here, and then we'll come and get you, or we'll have the group that was just ahead of you say, okay, it's your turn. Yes.
Dr. Patch, would it be possible today that you could present us this part of the lecture that was done by other professors? Because my group, the professor arrived very late, and I felt like we missed out of how we're supposed to do the skin examination the way you would like us to, etc. So would it be possible, if we have extra time today, that you tell us and verbalize
Absolutely.
how you would do that?
Either today or tomorrow.
Perfect.
Yeah.
Thank you.
Yeah, no problem. It might be in lab. It might be better in lab.
Okay, sure.
It probably would be a lot easier in lab.
Sure.
Yes.
If we're in the first group at 8 o'clock, we report to this room?
Yes. Yay, got through that part. Okay. The quiz for HEENT will be tomorrow morning. Okay. Yes. When it says, yeah, make sure you really wash your hands unless you happen to be, sometimes I have to assign people to the conference room, and then you have to pretend that you're washing your hands. If you're in the lab, you need to practice using the sink in the lab. If you're assigned to the lab, sometimes I'll assign students to the lab. Practice using that sink in there. You use your leg to turn it on and off. It's the same that you would do in surgery. So just so you know, before you get into his testing thing, how to turn that on and off.
Is it ever acceptable to wash your hands before you see the patient?
It really depends. Sometimes I'll wash my hands 2 or 3 times when I'm seeing a patient.
Okay.
I usually get the history first, and you don't have to worry about that in the practical exams. When you get to the OSCEs, you can do the history first and then wash your hands. Unless the patient I just saw was very contagious. And then, well, I usually wash my hands at the end of the exam, at the beginning and the end of the exam. For OSCE purposes and practical exam purposes, it doesn't really matter when you do it. But most patients that you see will have been sitting in the waiting room with the patients you've just seen prior to that, and they know they've been hacking, coughing all over the place and sick. And I like them to see me wash my hands. So I'll wash them after I see that patient, so I know I'm okay going to the next room, but I'll wash them then before I see them also.
Are we to wear gloves during this?
No.
Okay, I just hadn't been mentioned, I wasn't sure.
No, you can't feel the only time a skin exam I would wear gloves if somebody's oozing pus all over the place. I mean, if they have impetigo, then I'm gonna put gloves on. But anything else, you need to be able to feel the texture of the skin. That's one of the things you're checking. And you can't do that with gloves on. So you need to be able to feel, does that rash feel like sandpaper? And if it does, and they have a fever, and they have a sore throat, or they have nausea, I'm thinking strep throat. Because it feels like sandpaper. Well, you wouldn't know that if you had gloves on. So unless it's oozing and it looks like you could get something really bad from it. Same thing with breast exams, everything, don't put gloves on. Now, when you're feeling inside the mouth, yeah, I'm gonna ask you to put gloves on. Do I see another? Yes.
Just, this is a different topic, but for lab tomorrow,
Mhm.
do we need our ophthalmoscope and otoscope?
Yes, did you all get, there was some mix up there.
We
Did
didn't
you
have it
all
for
get them?
last. We had it the day after last.
Okay. Well, apparently they had arrived, but they didn't realize they had arrived, and that's what happens when I leave.
Yeah.
And they were here, you just didn't have them in your possession. So does everybody have their instruments now? Yeah.
I was just gonna say, please remember to charge them.
Yes. Make sure you're, for next week's HEENT, make sure your ophthalmoscope and yours are charged. And you have to follow the instructions on it, and you need it for lab tomorrow, so make sure for lab tomorrow they're charged. I think you have to leave them plugged in for several hours the very first time. 12 to 16 hours or something. So make sure that you, as soon as you leave here today, if you haven't already done. Now, after you do the initial charge, it doesn't take quite that long. So today we're shifting gears from general survey, skin exam, vital signs. We're switching over to the HEENT exam. And there's a lot in the HEENT exam. And when we get to the cranial nerves, the neuro exam, a lot of the neuro exam, the cranial nerves are the HEENT exam. So you'll see this again. But it takes a lot of time to practice this and get good at it. So first thing I'm going to do is show you the video, because I know, has anybody watched the video? No, that's usually the way it is. So, you know, if everybody raised their hand and said they'd already seen the video, then I wouldn't show it. But I'm going to show you the eye exam portion of the video first. Tomorrow we'll do the ear, nose, throat, and neck exam. The eye exam is involved, so I'm going to show you that first. Has the sound been working on this okay? It's coming, it's thinking. I see it go around and around and around.
You have to like drag it across.
Drag it across.
video begins with a brief overview of health history taking, followed by the anatomy of the head, examination of the head, skull, hair, scalp, and face, anatomy of the eyes, assessment of visual acuity, examination of the eyes and fundi, anatomy of the ears, inspection and otoscopic examination of the ears, and tests for hearing. We conclude the video with tips on describing your findings. You will see the examiner assess a healthy patient. In clinical practice, you may detect the same normal findings, or you may discover normal variations or abnormal findings. The health history interview is a conversation with a threefold purpose: to establish a trusting and supportive relationship, to gather information, and to offer information. In the case of new patients, you will gather information that will form the basis for a comprehensive written health history. For patients seeking care for a specific complaint, you may prepare a more focused, problem-oriented history. In either case, you'll record the patient's chief complaint along with common or concerning symptoms. Common or concerning symptoms relating to the head, eyes, and ears include headache, change in vision resulting in hyperopia, presbyopia, myopia, or scotomatous, double vision or diplopia, hearing loss, earache or tinnitus, and vertigo. By eliciting the patient's concerns before the examination, you prepare for an examination that is efficient and productive. With the patient's health history in mind, you are now ready for the examination. Before beginning, let's review the important regions and structures of the head. Regions of the head take their names from the underlying bones of the skull. The frontal area overlies the frontal bone, the temporal area, the temporal bone, the parietal area, the parietal bone, and the occipital area overlies the occipital bone. The superficial temporal artery passes upward just in front of the ear, where it is readily palpable. Two pairs of salivary glands lie near the mandible. The parotid glands lie superficial to and behind the mandible, and become both visible and palpable when enlarged. The submandibular glands are situated beneath the tongue, located deep to the mandible. The openings of the parotid and submandibular ducts are visible within the oral cavity. Now begin your examination with inspection of the head. Observe the size, shape, and position of the skull, as well as its proportion to the neck and the rest of the body. Note any deformities, depressions, or lumps. Inspect the hair, noting its quantity, texture, distribution, and pattern of loss, if any. Part the hair in several areas to inspect the scalp. If the patient is wearing a hairpiece or wig, ask the patient to remove it. Observe the scalp for scaling, lumps, lesions, scars, and lice or their eggs, which are tiny white ovoid granules that adhere to hairs.
That's important when we're doing the practical exam. Those of you who wear your hair in a ponytail or with barrettes or anything in your hair, it makes it a lot simpler if you take those out ahead of time. But if you forget to do so and you're examining a classmate that has a ponytail, you have them take that out. So don't hesitate to ask your classmate or a patient to remove that. You cannot do a proper scalp exam if somebody has barrettes in their hair or headbands or things like that. So make sure you have them take easier. And same thing with the eyes, in case I forget to tell you later. If you wear contact lenses on, which will be tomorrow's lab, it's best if you take your contact lenses out, because to do the ophthalmoscopic exam, it makes it easier for your classmate to see things without the contacts in. So, especially some contacts make things all sparkly looking and make it a little bit more difficult to do the ophthalmoscopic exam. So take your lenses out, bring your contact kit and the paraphernalia you need to put them back in, and your glasses if you need them for during lab. It makes it much easier to perform the eye exam without, except for the visual acuity, of course. Probably be off.
Palpate the scalp and skull for masses and tenderness. Assess the color and condition of the skin on the face, noting its color, pigmentation, texture, thickness, hair distribution, and any lesions. Look for scars, masses, and edema. When examining the patient's face, observe it at rest and during conversation, noting facial expressions and contours, and observing for asymmetry and involuntary movements. The cornea is the transparent anterior portion of the outer covering of the eye. External structures of the eyes also include the sclera, pupil, upper and lower eyelids, medial and lateral canthi, and eyebrow. Behind the cornea lie the lens and iris. The conjunctiva is a clear mucous membrane consisting of two easily visible components. The bulbar conjunctiva covers most of the anterior eyeball. It adheres loosely to the underlying tissue and meets the cornea at the limbus. The palpebral conjunctiva lines the upper and lower eyelids. A film of tear fluid protects the conjunctiva and cornea from drying and infection. This fluid comes from three sources: the lacrimal gland, which resides within the bony orbit above the eye, the conjunctival glands, and the meibomian glands, which open along the margins of the eyelids. Tear fluid from the lacrimal gland above the eye drains medially through the lacrimal puncta and passes through the lacrimal sac and nasolacrimal ducts into the nose. The fundus is visible through an ophthalmoscope. Fundus refers to the posterior wall of the eye. The retina is the light-sensitive membrane that covers the fundus. A transparent mass of gelatinous material called the vitreous body fills the eyeball and is not usually visible through an ophthalmoscope. The optic disc is the point where the optic nerve enters the retina. About 1.5 millimeters in diameter, the optic disc contains no sensory elements, making it insensitive to light. Most optic discs have a small central depression called the physiologic cup. The cup is lighter than the rest of the disc and less than half the disc's horizontal diameter. The retinal arteries and veins converge at the optic disc. Lateral and slightly inferior to the optic disc lies the fovea, which is the area of central vision. The macula surrounds the fovea but has no visible margins. Note the absence of retinal vessels in much of this area. To examine the fundus, light must pass through the pupil, lens, and vitreous body to reach the optic disc, retina and retinal vessels, macula, and fovea.
Step here, please, and when you test your vision.
Begin the eye examination by assessing the patient's visual acuity. Have the patient stand 20 feet from a Snellen eye chart. Patients who use contact lenses or glasses should wear them. However, patients should remove reading glasses because reading glasses blur distance vision. Note the visual acuity printed at the side of the line of the eye chart.
charts in your packets. Now, there's different ones. I'm not sure which ones they put in your packets this year. There's some that say 14 inches, and there are some that say 6 feet. So it depends on which one you have as to how you would actually examine a real patient's eye. We're going to pretend like you all have the 14-inch one. This says 20 feet. That 20 feet is the normal distance for a regular normal size Snellen chart. So you would have to mark off 20 feet, and most doctors' offices have that line on the floor where that 20-foot mark is, and have the patient stand there. But you're going to be using the 14-inch one on your little one. So even if it says 6 foot, we're going to pretend it's the 14-inch one, because not every place where we do the exam is going to have 6 foot available also. So even if it says 6 foot on it, let's assume it's going to be the 14-inch one for the purposes of the practical exam and what you're going to be doing here.
Visual acuity is expressed as two numbers, for example, 20/20. The first number indicates the distance of the patient from the chart, and the second number indicates the distance at which a normal eye can read that particular line of letters without the aid of corrective lenses.
And read the smallest line from right to left.
Repeat the test on the other eye.
D, Z, P.
Now, prepare to test the patient's visual fields.
Now we'll test your visual fields.
For screening purposes, visual fields are tested by confrontation. Face the patient directly and imagine a glass bowl encircling her head.
Look into my eyes with both your eyes.
Ask the patient to look with both eyes into your eyes.
Tell me when you see my fingers.
Then place your hands about 2 feet apart lateral to the patient's ears. Slowly move your wiggling fingers of both hands along the imaginary bowl until the patient identifies them. Normally, a person sees both sets of fingers at the same time.
Okay. Tell me now when you see my fingers.
Repeat this action in the upper and lower temporal quadrants.
Now.
If you think you have found a visual defect, such as loss of vision in the right temporal field,
good. Tell me when you see.
Slowly move your wiggling fingers from the defective area of the field toward the better vision.
Now.
Repeat this at several levels until you can define the border of the defect.
Now.
Then test the other eye for an accompanying defect.
Now. Now the other side. Look directly into my eye.
Next, visually inspect the patient's eyes. Observe for alignment and symmetry. Also examine the eyebrows and closely inspect the eyelids. Normally, the upper eyelid covers a portion of the iris, but does not overlap the pupil. Inspect the area over the lacrimal gland and lacrimal sac for swelling. To inspect the sclera, the bulbar conjunctiva, and the palpebral conjunctiva of the lower lid, ask the patient to look up as you depress the lower lids with your thumbs. Normally, the bulbar conjunctiva is transparent, with vessels running through it, and the underlying sclera is white.
Good.
To see the palpebral conjunctiva of the upper eyelid, the eyelid must be everted. The palpebral conjunctiva is pink and uncongested.
We're not going to do that this semester. But we will do this next semester.
Carefully inspect each iris and pupil. Normally, iris markings are clearly defined, and the pupils are round and equal in size. With oblique lighting, inspect each cornea and lens for opacities. To do this, shine a penlight from the side toward the eye. You should see no opacities. Next, test the pupillary reactions to light. First, darken the room. Then ask the patient to look into the distance.
Look off in the distance.
Shine a bright light obliquely into each pupil in turn. The oblique lighting and the distant gaze both help to prevent a near reaction. Look for the direct reaction, consisting of pupillary constriction in the eye being illuminated directly. Then look for the consensual reaction, which is pupillary constriction in the opposite eye. Typically, in a darkened examination room, you will need to quickly illuminate the patient's opposite eye in order to provide sufficient light for direct observation of the patient's consensual reaction.
I think that's a little ridiculous, personally. This is where I disagree with how you do this. A better way and more efficient way of doing this, in my mind, is to darken the room, but crack the door just a little bit. So you, first of all, so for your own safety, so you don't trip over something. So darken the room, but then it's going to be hard to do this in the lab, but it's easy to do in the exam room. But then you crack the door just a little bit, so there's a little bit of light coming in. So you're not going to notice as big a change with the constriction, but you're still going to notice it. And that will allow two things. One, when you do, I asked you to put a piece of paper here, like your index card. Always have a couple index cards available. They come in handy for several things. So put your index card here and flash the light into this eye and look for the changes in this eye. Then you're going to flash the light in this eye again, but you're going to be looking at the opposite eye. So the light's flashing in here, but you're looking in the opposite eye. You should notice some constriction, not as much as the direct, but you will notice some consensual constriction in the opposite eye also. What she does on this exam is she shines her light in that eye. I don't know how you can tell the difference between direct and consensual constriction when you do it that way. So if you do it the way I'm telling you instead of the way this shows you, I think you'll be able to see the difference better. So just crack the door a little bit. The room's dark enough. Crack the door a little bit so you don't trip, and check direct. And then you're going to shift your eyes and look at the person's other eye, but you're going to shine it in that same eye you just shined it, and you're going to notice consensual constriction, not as much, but some in the other eye. Does that make sense? We'll go over it in lab too. But that's one thing I do have in disagreement with this. I think it's just easier to do it the way I just described it. The fishbowl thing, we'll do it in lab tomorrow. It is sort of a good way to remember that you're coming around the head like you would in a fishbowl. But we're going to actually have you close one eye while the person closes the eye on the other side. So for instance, if I am, and you have to be directly across from each other. If one person's real tall and the other one's short, you got to figure out some way to make your height similar. So one person may have to sit on the chair and the other one stand up, or we'll do whatever we need to do to make it work. But you're going to have the patient, let's say, close their left eye. Well, if the patient closes their left eye, you're going to close your right eye because you want it to be the eye right directly in front of you. And then you're going to wiggle your fingers, and you're not going to do it like this. You can't do it like that real fast because they can't say the word now fast enough to be able to, so that you will know. What you have to instruct the patient to do is when you can see both of my hands move, they're going to see one earlier than the other. When you can see both of them, then I want you to say the word now. Assuming your vision, your peripheral vision is normal, which is a big assumption to make, it may not be, and if you know it's not, then you can't do this test anyway. But if your peripheral vision is normal, you'll be able to see both hands at the same time, just as the patient does. So that's you're the control in this instance, in this test. It's a screening tool. It's not a definitive tool on field of vision, but it's a good screening tool to use to see if somebody, you would do it if you're worried about somebody having a stroke or a brain bleed or a clot of some sort. So that's why you would use that. So we'll do this in lab so you can see it a little bit better. But that's why they say to look at it like they have the fishbowl, because you're going to be coming around. You're going to do it 6 different ways. So here's 2, 1, 2, 3, 4, 5, 6. We're going to do it 6 different things. 1, 2, 3, 4, 5, 6. It'll make more sense when we're in lab doing it together.
Next, assess ocular alignment arising from the extraocular muscles. From about 2 feet directly in front of the patient, shine a light onto the patient's eyes and ask the patient to look at it.
Look at this light, please.
Inspect the reflections in the corneas. They should be visible slightly nasal to the center of the pupils. Next, assess the extraocular movements, looking for the normal conjugate movements of the eyes in each direction, or any deviation from normal. Nystagmus, lid lag, and convergence.
Now we'll test your extraocular.
You will check the extraocular movements in the 6 cardinal directions of gaze.
Follow my finger.
These directions correspond to the coordinated action of 6 muscles involved in eye movement innervated by cranial nerves 3, 4, and 6. Stand 2 to 3 feet in front of the patient. Ask her to follow your finger or a pencil as you make a wide H in the air.
Now I'll test nystagmus.
Look for the jerky movements of nystagmus on lateral gaze and on upward gaze. A few beats of nystagmus on extreme lateral gaze are normal. In a patient with lid lag, seen in hyperthyroidism, watch for a rim of sclera between the upper lid and iris as the eyes move up and down. These movements should be symmetrical and conjugate. Test for convergence of the eyes by asking the patient to look at your finger as you move it toward the bridge of the nose.
Now follow my finger.
Eyes can usually follow your finger to within 5 to 8 centimeters of contact. Next, after darkening the room, conduct your ophthalmoscopic examination. Switch on the ophthalmoscope light and adjust it to the large, round beam of white light. Also, make sure the light is set to the appropriate brightness. Set the ophthalmoscope to the 0 diopter. Ask the patient to look over your shoulder at a specific spot on the wall.
Now look straight ahead at the dot on the back wall.
Remember to use your right eye and right hand as you examine the patient's right eye. From 15 inches away and 15 degrees lateral to the patient's line of vision, shine the light beam on the pupil. Placing the thumb of your other hand over the patient's eyebrow may steady your approach and allow closer examination. Locate the red reflex, which should appear as an orange glow in the pupil. Note any opacities that interrupt the red reflex. While holding the red reflex in view, approach the patient's eye along a 15-degree line lateral to her line of vision until the ophthalmoscope is close to the eye. Try to find the optic disc by following the retinal vessels centrally toward the place where they converge. Now, using your index finger, bring the optic disc into sharp focus by adjusting the diopter of the ophthalmoscope. Note the color of the optic disc. The clear.
See that the little bright light? This is one of the hardest things when you're doing your ophthalmoscopic exam until you understand the concept. Because all the pictures in your book, you see this whole big picture. You think that's what you're going to see when you use your ophthalmoscope. No, not unless you're using a panoptic. If you're using a panoptic, which is a big, fancy, expensive piece of machinery, you will see this whole picture, not just the little white part. If you're using the one that we've asked all of you to get, all of you got the small head, right? And the reason we want you to use that instead of the panoptic's a nice toy for people who want to have that. Maybe they're going to go into ophthalmology, they think, or have more money than God and just can buy whatever they want. Then it's really nice to have it. And those of you who bought it, because they're too expensive and they're not gonna have them hanging on the wall. So you have to learn how to use the small head, which is the one we asked you to get. But the thing is, when you're using it, this is all you're seeing. There's this little circle of light here. So you're not gonna see this whole thing. And it throws you off at first because the first couple days, the first few times you use it, if you get a red reflex, I'll be happy. If you just get the red reflexes, which is what means that you're in the right place. If you can see vessels and things within a couple months, that's great. So don't get discouraged. Don't think you're going to be seeing everything the first day. The vast majority of people don't, unless they've used them before. But you're going to, once you learn how to focus it, which is what they're going to talk about here in a minute, focusing it, you're going to be able to see these vessels. And what you want to do is you want to, once you find a vessel, follow that vessel medially toward the nose. And then you're going to find this lighter part, which is the disc and the cup. So eventually you'll be able to do that, but it's a lighter color. Everybody's retina looks different. It's a different shade depending on your skin color. It'll be pale or darker. So don't expect them all to look the same. They're not. And there'll be other things that we'll look at. Over here, this little spot over here, this is the fovea. And around the fovea is the macula. You hear people having macular degeneration. This is what they're talking about, the macula degenerate. This is very light sensitive, the fovea. So one of the things we ask you to do on this exam is look into the light. And when we ask the patient to look into the light, we're assessing the fovea. But you can't have them do it for very long because it hurts their eyes. So mainly you're just going to see, I say it's like you're looking at Venus at night, right at dusk when Venus just starts to come over the horizon and you have that glowy look to Venus. That's what this looks like, that sparkle almost of a planet on the horizon. But when you're looking with your ophthalmoscope, you're only going to see this small part. You're not going to be seeing this whole thing. So don't get discouraged if you can't see the whole thing. Nobody can see the whole thing unless you're using a panoptic. So those pictures you see in the book are with a different camera and with the panoptic.
30 of its margin and the size of a physiologic cup. Normally the disc is yellowish orange to creamy pink and round or oval with well demarcated margins. It may be surrounded by white or pigmented rings or crescents. The optic cup to disc ratio is usually less than 1 to 2. Adjusting the angle of your head and instrument and moving them as a unit. Inspect the retinal vessels and adjacent retina by following the vessels from the disc to the periphery in 4 directions. Note the relative size and color of the narrower, lighter arteries and the larger, darker veins.
Just the opposite of what you usually think. The arteries are the smaller ones, the veins are the bigger ones in the retina.
Look for changes, such as nicking of the veins at arteriovenous crossings. There should be none. Examine the surrounding retina for hemorrhages or exudates, noting their size, shape, color, and distribution. Again, there should be none. Finally, examine the fovea and surrounding macula by directing your light beam laterally or asking the patient to look directly into the light. The tiny bright reflection at the center of the fovea may help orient you. To focus on more anterior structures, such as opacities in the vitreous body of the lens, change the diopter on the ophthalmoscope to more positive numbers, such as +10 or +12. Repeat the ophthalmoscopic examination on the patient's left eye, using your left hand and left eye.
Okay, we're going to stop there. We'll do the ears, nose, throat, neck tomorrow. show you exactly what we're gonna do with it tomorrow. But those of you who are right-handed, get used to holding it in your left hand. Because I'm gonna ask you to do it. You have to be able to use it in your left hand because you use your left hand for the patient's left eye, your right hand for the patient's right eye. And you have to do it that way, and I'll show you in lab tomorrow why you have to do it that way, or you won't be able to examine the eyes without making your patient uncomfortable. So that, if you want to see that again, if you have questions about that, we're gonna go over some other things here in a PowerPoint. But if you want to see that again, this is available to you. You can get it through your book, online through your Facebook, or you can go to the library. The librarian was here the other day. Did he show you how to get onto the Bates things I asked him to do? So did he do that? Yeah, Alex?
Oh, I was just gonna say, I can tell you how to do it. I was just doing that. I was
Okay.
trying to download it, but I can't seem to get it. So you have to go to the actual website.
Yeah, but it is available in the library. If you go to the HPD library, go to the physician assistant section, and there'll be a Bates
Clinical resources on the page.
So make sure that you look at that again if there's any question on all that.
I was looking for